right, it's exactly 9:30. Thank you, everybody, for coming. What a great show. A lot of familiar faces. If I tell some stories and people have heard that already, I am sorry. Bear with me. But for the new people who don't know me, my name is Martha Cullen. I'm the nurse practitioner here at John Knott's Village. I wanted to kind of share a little bit about myself, both personally, maybe a little bit. These are questions that have been asked of me throughout the years. So some personal questions, some professional questions. The main thing is, I'm married, third time, 3 times a charm. So I might be good at nurse practitioning, but I'm not good at marriage, apparently. No children. I don't have any children. I have just one 4-legged dog. A lot of people here are into genealogy, so they want to know my background. I am Mexican. Both of my parents were born in the Yucatan Peninsula in Mexico, and they're actually there now. So I'm kind of watching the news and keeping track of what's going on with the violence and the cartels and everything. But so far, they're safe. They live back and forth. They live here in Lake Mary, and they travel to Mexico. They're both alive. My dad is 91, and my mom is 86. Not loud enough? Thank you. My father moved to Vermont from Mexico. He was recruited by Vermont Marble when the Kennedys were in office, and Jackie Kennedy was redoing the marble in the White House, so they needed, first they went after some Italians, and then they went for the Mexicans. Up closer. There? And so my dad, at the age of 26, they recruited him, and he went over legally to work in Vermont. He was my brother, his older brother was going to college there, and so he sponsored my father. And in the fall of 1961, he went to work at Vermont Marble. 5 months later, he sent for my mom and my 2 older sisters. And being a good Mexican man, it wasn't long before I was conceived, and so I came baby number 3. I was born in November of 1962. They lived in Vermont, although they never got used to the cold. So when I was about 13 years old, we moved to Central Florida. And I remember being in, I think it was middle school, we had a career day, and I came home and I told my mom I wanted to be a school teacher. And then she showed me how much school teachers made. And even though I had a love for teaching children, I had a bigger love for money. So I decided to go and become a nurse. So in 1984, I graduated with as an RN. I went to a community college in Orlando. And I worked in mother-baby, labor and delivery, and pregnancy high risk. So very different than what I'm doing now. Although, when I worked in labor and delivery, there is a similarity. Because when I worked in labor and delivery, parents, especially the mothers, they would just go all out because they wanted a good experience. When they were going to bring life into this world, they wanted a good experience. So they would research the hospital, they would research the obstetrician, they would come up with a written birth plan. And I used to really pride myself in being a part of that. If I was a labor nurse, I wanted that experience where they brought that life in to be a special experience. And now that I'm working with you all, and we're at the opposite spectrum, I do pride myself, and I try to make this experience as good as I can. So I did that for about 20 years, and then I went back first for my bachelor's, and then for my master's degree. Back in 2002, there were only Gainesville, University of Florida had a nurse practitioner program, in Miami. UCF was just beginning to open one, so I kind of wanted to go where I knew the program was established. The other difference from the master's program in nursing to now is we only had 3 tracks. So you had to do either adult, family, or acute care, where you'd end up working in the hospitals and the ICUs. They don't have all the other different tracks like they do now. They didn't have online courses or schools for sure. So I elected to go to University of Florida, and I graduated in 2005. And while I was there, there was a nurse practitioner that said it would as a guest speaker, and she kept saying how important it was that to start out you work in cardiology. And I knew nothing about cardiology. I was afraid of cardiology, and I joke around and I say the only thing I knew about the heart at that time was that it pumped blood to the uterus. That's all I know about. So, and realistically, who was going to hire a nurse with a degree that had a 20-year experience in mother-baby? So, like, my chances of getting into cardiology were probably very slim. However, unfortunately, my sister died in 2005. Oops. Catch me every time. She was my little sister. She was 35, and she died of cardiac arrest. And in trying to find out what happened, we realized that she had a genetic disorder that caused her electrical system to kind of go astray, and so she died suddenly. And we all had to get worked up because it was genetic. And so as I was going for my cardiac workup, I heard that the cardiology group was looking for a nurse practitioner. And lo and behold, in my interviewing process, even though I had the experience all in, mother-baby, they did listen to me because they knew I had a passion now to learn about the heart. So they did give me a chance, and that was a big blessing because you do indeed get a good, rounded education. I was working in the hospital rounding for the cardiology group I worked for, and I worked side by side very closely with the kidney specialist, the lung specialist, urology, a variety of different doctors and nurse practitioners. So I really do feel I did get that well-rounded education. So I worked for that cardiology group for about 3 years, but I was traveling from Volusia County to Orlando. And so you can imagine in 2008, when I was doing that, the cost of gas and how much it was, it was costing me about $140 a week at the time. So I tried to find, an office closer to home, and I did in Orange City. I worked for a primary care doctor. And at that time, I'm still in my late 40s, I always believed, and I still do, that when you're young, you never know when something is going to come up and you're going to lose your job or something's going to change and you need to go look for a job. So you really need to hone in your interviewing skills. So if a job came across my desk, I would go for an interview just to practice. I knew that I could look good on paper and sit for the interview and blow it. So that's what I would do. And so I came home one day after work, and there in the mail was a letter from John Knox Village. And so I am telling you that I came here for an interview for the sole purpose of practicing my interviewing skills. But when I met the administrator, when she took me around and I got to see the campus and I knew what John Knox was all about, I fell in love and I found my home. So here I am. I started working in June of 2002. When I first started, I think my job description wasn't very clear. I think originally I was to reduce hospital admissions or readmissions. So I'm not sure if you all are aware, but if you are in the hospital and you go to a skilled facility, if you have to go back for certain reasons, Medicare won't pay. So they expect when the hospital, like for example, Peggy, if you were to have hip surgery, Medicare expects that the hospital releases you that you're healthy enough, you can go do your skilled care and not have to come back to the hospital. By the same token, if you end up in the skilled facility, they expect the doctors and the nurse practitioners are skilled enough that they can take care of anything that happens to Peggy, that we can keep her from going back to the hospital. So they started holding back on payments to the hospitals. So therefore, if you have a reputation as a skilled facility and you keep sending people back and forth to the hospital stops referring patients to your facility. So we have patients that are admitted are residents, but we still need the outside source referrals. So originally I was started for that purpose, but then eventually the Oak Park Clinic, which is now the John Knox Clinic, opened, and now I see patients who I do acute and chronic illnesses, and I'll explain that here in a little bit. I do work autonomously. nurse practitioners used to have a supervising physician, and when you first start out, you still do. And then, after you've practiced a certain, I think it's like 3,000 hours, you're allowed to apply and work, so you don't need a supervising physician. And they made that announcement like I think like the summer of 2020, but the day that they were going to accept applications was a Friday. Oddly enough, it fell on a Friday in October. And I remember I went through, I saw that I qualified, I filled out the application. My husband called Tallahassee, and he found out who the receptionist was that was going to be actually taking in the applications. He found her where she worked, he found out the time her office opened, and he drove to Tallahassee with application in hand and the fee, he turned it in. He was waiting when the doors opened, he handed it to this lady, and it was like the next day was a Saturday, and I checked my email, and I had been approved to work as a nurse practitioner. But I think you all are looking at the very first nurse practitioner in all of Florida who was accepted to work at Thomas Lee. Yeah. So as I said, the intention at first was when I opened up the office was to see more acute care, because people here the residents here already had their primary care doctor. So if you have a primary care doctor and you have a sore throat, or you have a wound, or you have an upper respiratory infection, then I would you could come see me. More and more people started asking if I could be their primary care provider, because I was able to handle chronic diseases like kidney disease, diabetes, heart failures, and then refer, of course, to specialists if needed. So I have been taking on more and more private patients. If you do have your own primary care and you want to see me, I do ask that you call your own doctor first. Of course, when we opened up this office, it kind of ruffled some feathers out there with the doctors. There was actually a letter sent to me that Joe Traynor had to manage with one of the doctors' groups, a local, forbidding me to see the patients. So he did have to step in, but they get it now, and things in all these years, in 14 years, things have managed to stay calm between me and the other doctors. We work well together, so, but I just do like to respect them and not step on toes. So if you have your primary care, just call them. If they can't get in to see you, then certainly give me a call. I will handle, again, acute issues, but if you have your own primary care, if it involves diabetes, blood pressure, something like that, then yes, you need to go see your primary care, because that's a chronic issue. He has your lab values, he has all your diagnostic testing, he has all the records from your referring physicians. It's just a safer way of managing those issues. Office hours are Monday through Friday, 8 to 4. We close between 12 and 1. We draw labs Monday and Friday. We're going to actually start a new lab, a new old lab, because they used to work with us, and now we're bringing them back, Vista, and Monday through Friday morning by appointment. And I do want to clarify one thing that comes up all the time about the labs. If I am your physician and I am concerned about you and I need to know about your lab values, so let's say you're on a medication and I'm worried about your kidneys, and I said, I want to draw labs, I want you to come back in a couple weeks and we're going to review it. That is my responsibility. The onus is all on me to make sure I get those lab results. If they have not come, then I need to have my secretary call you, or my receptionist call you. Where did you get your labs drawn? Because you have an appointment coming up, and I need to make sure I get those. When you all go to your doctor's appointment and they say, we did not get your labs, it's been 2 weeks since you've had your lab draw, and they still don't have those lab values, and they blame it on the lab, that is not the case. It is their responsibility. In this day and age, even with modern technology, paperwork gets lost, faxes don't work, there's glitches in the system. So I don't think I've ever had a patient come in and I have to turn them away, make them pay me, and then turn them away and say, sorry, I didn't get your lab values. So just just want you to, when you leave messages for me, usually my day consists, I usually go like room to room to room, back and forth between the exam rooms. I might run into my office to chart a little bit, but prescription refills and messages you leave me, I usually get those at the end of the day. So if it's something that's more urgent, please let Celia know, and then she'll stop me in the middle of my day so I can address those. I just don't want you to think that I'm ignoring you. We do have different doctors or specialists that come to the facility. We're trying to get more. Unfortunately, I had a dermatologist recently, that didn't work out. But we still have Dr. Duffus. She comes every Tuesday. She was coming every other, but now she does come every Tuesday. We have Fred, my hearing aid specialist. He's been coming here like on and off for I think about 15 years. He purchased a sound booth, and so he does do free hearing screens. And he will work on hearing aids even if he didn't sell them to you. He's a good troubleshooter, so it's always, if you want to just come see him for questions, that's Dr. Rachel, she is a psychologist, she does psychotherapy, and she usually comes like 1 or 2 Thursdays a month. She has been known to do phone or Zoom sessions. To access anyone in the clinic, you call extension 2710. That would be for either me or Celia does make appointments for Fred, the hearing aid specialist. Dr. Duffus, we have these, you can pick up one of these from Celia, and it has her phone number. She's asked that she makes her own appointment, so people call and ask if we can make an appointment for her. And then Dr. Rachel, she has an extensive packet to be filled out, so we print one out for you, you fill it up, and then Celia passes that information, and Dr. Rachel will call you. How do you sign up to see me? Again, you call Celia extension 2710. She will verify the insurance, and then there's a new patient packet you fill out. I always say if you have an extensive medical history, it's always better if you can to make an appointment before you get sick. So if you're not sure if you have an extensive medical history, here's a packet. If you have to write C attached, it's extensive medical history. Believe me, but it's no fun if you're feeling sick and we have to go through all the information. So let's see, whoops. Okay, so as I said, when I went to school, they only had the 3 tracks: adult, family practice, and acute care. When I did my adult practice, they did have some courses on gerontology, or a few classes on gerontology. Gerontology, a lot more patients that are older are encouraged to go see a gerontologist. It is a totally different way of practicing medicine, very different than primary care. And since I work with a primary care doctor, I kind of see what the difference is. I'd like to explain that to you. It is seeing patients 65 years or older. It's chronic instead of immediate physical ailments. So if you sit back and think back to when you were 20 or 30, when you went to the doctors, you were there like minutes. You had a sore throat, you walked in, or if you had a cough, they treat you from bronchitis, out the door you go. When you go see a gerontologist, if you go in with a cough, well then they have to say, well, could it be heart failure? Could it just be bronchitis? Is it a COPD exacerbation? 80% of people 65 years or older have at least 2 chronic diseases. So chronic diseases, along with that comes medications, and so all of that is included in making a decision, a plan of care, and it's just not an immediate in and out visit. Gerontology, when you make or have a relationship with your doctor and you've seen him or her throughout the years, you have to have conversations, and this is the worst part, I think. of my practice is these uncomfortable, no fun conversations about long-term planning and end of life. So is it time for you to have to move to a higher level of care? Is it time for you to have someone manage your medications or to involve your POA or children? So these are very uncomfortable. No one wants to do it. And so it does take time, and you have to feel comfortable with a clinician you have. You have to be able to trust what they're telling you is your best course. I call you all my human Rubik's cubes because your care is definitely multifaceted. So I don't just treat the sore throat and, like I said, out the door you go. When you come in and you're sick, we have to, especially here in John Knox, do you need additional help? Do you need to have meals delivered? Do I involve your children? Sometimes we have to explain because of dementia, and people get confused. I have to write out the instructions. We have to call and make sure that they are following what the plan of care is. And because of that, an average primary care visit, because it's just immediate and simplistic, they spend 5.2 minutes with you. A physician will walk in, and they do schedule to see a patient every 5 to 10 minutes when you go to a primary care. For a gerontologist, the average time is between 20 and 45 minutes. I was going to mention medications. This is an interesting statistic. 50% of people 65 and older take at least 5 medications. I think it's probably more. I've seen more. But 20% they take more than 10, and this does not include supplements. All right. This is my favorite part of gerontology. The primary goal is to work on a person's quality of life. So whenever I prescribe a medication or a test that needs to be done, always in the back of my head is this going to improve your quality of life? What can this do to help you enjoy these golden years that you're in? And that involves time and negotiation and education and instruction. I need to align what my care I think should be with what your goal is. And because of that, that's what takes up the 20 to 45 minutes of time a lot of times. And you can't, and that's something that cannot be rushed. And why do I say that? I think I've said this to many of you, your health is like your investment portfolio. You all did not move into John Knox and say, oh my God, I have to have an investment specialist. I need to start stocking away my money. I need to save, because oh my God, this is, I need to have money to live. That should have been done years ago. Now is the time to go on those cruises. Now is the time to do that. You want to enjoy your life. By the same token, your health is the same thing. You all should have been eating healthy, exercising, strength training, all that should have been done in your 20s, 30s, 40s, and 50s. Not that I want you to stop now, and I'll explain that, but do you have to? Should you? Would it make a difference? Possibly not. It takes decades for plaque to build up in your blood vessels. It takes decades for your organs to be damaged by blood pressure problems. It takes decades for your organs to be affected by high sugars. So, according to the books, theoretically, if you were a healthy eater, exercising, you went to your doctors, if they had to start you on cholesterol medicine, let's say you did, you got your blood work every year like you were supposed to, you always hit your goal, always on target, and you did all those things, and then you move into John Knox when you're 70, 75, that means you should be able to stop your medicines, theoretically. You shouldn't have to exercise aggressively or do any of these things. It's going to take 10, 20, 30 years for you to do any kind of damage, okay? But I know a lot of you out there, my patients are going, wait a second, Martha, you started me on a statin medicine just the other day. So why do we do that? Why do doctors do that? Why do we still insist you exercise? The bell curve. How many people remember the bell curve at school? The bell curve says that most of the people, this is how standards of care are developed. This is how we come up with screening processes. So that's like the bell part of that curve is like sometimes 80 or 90%. So let's take colonoscopies, for example. Colonoscopies, insurance companies do not want to pay unless you're 50. They're bringing it down to about 45 now, but it's been 50 years old. Why? They don't do it because cancers normally start, most of the people, the bell curve says, 80% of the people are going to could get cancer after 50. Now, we all have been around long enough that we know somebody. Well, I know somebody who was in their 20s and got cancer. Yes, that can happen, but it's a very small amount. According to that bell curve, it was like 5 to 10% of people that fall outside of that. So, if you have been doing everything right, if you've been exercising, if you've been eating, and you move to John Knox, can you stop the medicine? Can you go to your doctor and he goes, you know what? You don't have to take your statin anymore. Would he be wrong? No. Is that negligence or anything? No, that's okay. That's what and I've had patients come in and they say, my doctor says I don't need to anymore. This is why, because the bell curve says that you're fine, that it's gonna take 10, 20, even 30 years for you to plaque. But could you be one of the people in that small little percentage? Could you be that person who's outside that bell curve? And what if you plaque in 5 years? What if you plaque up in 3 years? So then you get someone that goes, nope, there's a doctor that says, I want you to take a statin medicine. Is he wrong? No. So that's why we don't have, when you're in gerontology, we don't practice cookie cutter medicine. Think about when you have your children and you go to a pediatrician. Everything is exactly cookie cutter. 4 months they get their DPT shots, they walk in, they weigh them, they measure their head, and they have their injections. Everything is exactly the same. When you get to this age of your life, there's negotiation, we discuss your history, what your goals are, why or why not to be on a medication or have testing. And so I just want you to understand that your care should be very individualized, and you should be able to take time and have this relationship with your doctor so you feel confident with what he has planned for you. I try, when every decision I make, I go, my goal for my patients, again, the quality of life, I want them to feel cared for. I want them to have dignity. I want them to be clean. I want them to have their independence. I want them to have as little pain as possible. And so that's how I make my decisions along with my patients. I do use the standard of care, but like I said, sometimes there's 2 different ways of doing something and they're both right. What I don't want, and this is what I see, this is a typical PCP patient. This is when you go just to a regular doctor. This is Sherry. So she can't see a gerontologist, so she goes, 46 years old, she goes with abdominal pain. How much time is the doctor going to spend with her? 5 minutes, 5.2 minutes. So what does he do? He refers. Is that wrong? No, that's okay, that's safe medicine. So he's going to send her to a gerontologist, but what's a gerontologist going to do? Test. And yep, and you know that. Colonoscopy, automatically, endoscopy, maybe an ultrasound here and there. Let's start her on a proton pump inhibitor, let's give her omeprazole, or let's give her some medicine, and then follow up. So now she's got to go back to see him. He tells her, no, that's not the cause of your pain. Now what? Now she's got to go back to her primary care, and then he asks a few more questions, gleans a couple more symptoms. Well, let's try a urologist. So now she goes to the urologist, and more testing, more medications, more follow-up. Nope, that's not the cause of your pain, so back to her primary care. And then he says, well, let's try gynecology. Internal exam again, more testing, more labs, more medications, and a follow-up. Well, this primary care, he's just like, I don't even know anymore. So he goes, could it be in your head? Are you stressed? So she goes, psychiatrist. You took out my slide. I had the cutest little slide here. It was a person's crazy. I hope you didn't take it out on my other slides. Is this the? Yeah. No, yeah. This is not the other one. Okay. Let me. I'm going to have to jazz things around a little bit. Hold on. Okay. So, anyways, it was a cute little picture of a crazy face. Okay, because the psychiatrist is just going to say you're crazy. So that I see, and it happens even more so when you're in gerontology, because you have little blips in the blood, little things that they're going to see. When you're almost, when you're in your 80s, 70s, 80s, you're almost 100 years old. So your body's not going to be perfect. I want you to find someone that you trust that would sit there and go, here's the reason I think you're okay. Let's just go ahead and monitor between me and you. Let's not have you having go doctor to doctor. I want you to live your life. I want you to enjoy your life. And I want you, this is towards the end, okay. This is one of my favorite sayings in one of my favorite movies. It comes down to a simple choice: get busy living or get busy dying. And what I see when people are just constantly trying to find out every single little thing that could possibly be wrong with their body, they're trying to get busy dying. And so I want you all to have, like I said, the best quality of life at this stage of your. Let me see. I'm going to have to shift things around a little bit. Hold on. Okay, so it is National Heart Month. That's where I'm wearing red. And I was asked to say a few things. So I was going to start out with some fun facts about the heart. The heart beats 100,000 times per day, which over a lifetime you could pump up to 2.5 billion in a lifetime. If you were to grab a tennis ball and you squeeze really hard as you can on that tennis ball, that's how hard your heart beats each time. It's a pretty impressive muscle, isn't it? It beats 60,000 miles of blood vessels, so like your blood vessels can wrap around the earth twice. This is something I've only seen one time in one of my textbooks, and I quote this a lot. For every 2 pounds you're overweight, your body has to make 400 miles of blood vessels. Now, athletes have more blood vessels, but the blood vessels are in the muscles. So as they're walking or running or exercising, the muscles actually beat for the heart or help the heart beat. If you are just overweight, then the 400 miles are in adipose tissue. So your heart has to beat for every single one of those miles. The heart beats blood to every single cell with the exception of the cornea in the eye. This was new to me. Most heart attacks occur on Christmas Day. Odd, right? I don't know if people are opening their presents and the Father sees how expensive everything is. But followed by New Year's Day, and more heart attacks occur on Monday. I did have another slide here, but that didn't get in. So these are the not so fun facts. I'll just read these to you. Heart disease is a leading cause of death in both men and women. Still, after all the science, all the research, in 2000 till last year, 800,000 people died due to cardiac disease. More deaths from heart disease than cancers and Alzheimer's combined. And isn't that odd, like in October, everything is pink, football players are wearing pink, and they just put so much effort into advertising for breast cancer awareness, and yet heart disease kills more people, more women even. Men develop heart disease up to a decade earlier than women, so like mainly in their 60s, where women in their 70s, and it's because of the estrogen. Estrogen protects women. Women die more often than men with their first heart attack, or soon after, within 5 years, they'll die. And here's the reason. When men have heart attacks, it's because their big blood vessels are plaqued. When women have heart attacks, it's because the smaller blood vessels are plaqued. So those big blood vessels, when you hear of the different symptoms that are associated with a heart attack, it's the very classic ones. So it's when the big blood vessels are plaqued. So that chest pressure, going up to the left shoulder or the jaw, that's typically what men feel. Women, because it's the smaller blood vessels, their symptoms are very subtle. So that's why they're unaware they're having a heart attack. They don't seek help until they collapse. The reason they die after a heart attack soon, like within the 5 years more so than men, is again, the larger blood vessels, we have a way to fix them. We do a heart catheterization, we take a stenting, we open up the blood vessels. Those are the large blood vessels. The small blood vessels, we have no way of treating. So if a woman has a heart attack, those blood vessels, there's nothing we can do. So the American Heart Association came up with some recommendations, and now it seems like I'm going to be talking out of both sides of my mouth, because I just said that there's really nothing you can do because if you've done any damage by now, it's already done. So I think I was saying, like, if you were very, very healthy all these years, that now you should be able to live a little. By the same token, if you were eating McDonald's and French fries all these years, never exercised, overweight, can you come in now and say, oh my God, I got to exercise, I really need to get in shape? Well, just like your financial portfolio, now is not the time. There really, supposedly, isn't anything you can really do to make a difference, with the exception of the fact that we have that bell curve. So maybe, if you do exercise, you can make a difference. Maybe you're one of the small percentage that, yes, it does make a big difference. So I do encourage people. I do it for a different reason, though. I like people to exercise. I like it because it's social. I like you to take walks. I like you to get vitamin D. I don't want you to gain weight because it's hard on the back. It's hard on the knees. I don't want you to have to buy a whole new wardrobe. That gets expensive. So I still like you to follow these rules, maybe for a little bit of a different reason. But physical activity, the American Heart Association defines the difference between vigorous and moderate. So 75 minutes of vigorous per week, which means that you should be sweating. But when you're exercising, it should cause you to sweat. It would be difficult for you to carry on a conversation, so you should not be able to talk. You could do 150 minutes of moderate per week, and that means that you're walking, and you could carry on a conversation, but if you tried to sing, you wouldn't be able to because you'd be out of breath. Again, I still think any kind of daily activity, anything that makes you move and increases your heart rate even a little bit is healthy for you, especially if you're doing it with a group of people. I like that socialization. It does help, like with even like dementia. These are some other recommendations, and they're really numeric, and they're really very specific. Some of these recommendations. This is probably for the younger crowd, and I'll show you what I mean by the next slide. But sodium less than 2,300 milligrams per day. Less than 6% saturated fats. So if you eat 2,000 calories a day, that would be about between 11 and 13 grams. And everything is labeled these days. And if you go to the restaurant, a lot of times everything is delineated for you there. You want to, of course, eat healthy things, fruits, vegetables, whole grains, avoid processed foods and sugar in moderations. And again, we do want you to try to eat healthy, but I do hear that when you go to the restaurants here, they have gravies and some people feel the foods aren't the healthiest. And again, the menus are made with the idea that now is the time you should be able to eat a hot dog every once in a while, or wings and beer, and you should be okay. If you've invested in your health all those years, now is the time for you to enjoy yourself. I like this. Now this was, I found that copyright is actually 2025, so I think the Heart Association was like right on target with me about not being so strict, especially with people in your age group. So there's no numbers, there's no goals. It's just everything that's listed is talked about moderation. So limit your alcohol. Just try to cut down on salt. Eat minimally processed food. So everything within moderation. And I want to take a time, the sample I showed about the abdominal pain, I did have older couple that lived here, residents, and they're both in their 90s, and so she had like a abdominal. It wasn't real pain; it was like a discomfort. But when she had one of her spells, we would call it, she did not want to get out of bed, and she would didn't want to eat, maybe drink a few things, and so her husband, of course, would fret. And he would worry, he'd run back and forth, and like, well, how about a cracker? What about soup? And he would just try to get her to eat. In his mind, it was just not right that she wasn't getting out of bed and she wasn't eating her meal. She wouldn't take her medicines. That wasn't right, so he'd keep going back and forth, and she would get upset, and she'd want him to leave her alone, and she just wanted to sleep. And so this went on and on until finally in the evening, he's like, that's enough. So he took her to the emergency room. So they tested her, they admitted her, all the testing, like we said, follow-up, GI specialist, they found nothing. But oddly enough, while she was in the hospital, the very next day she woke up after her admission, and she felt great. And she ate, and everything was fine, so the doctors saw her, and they went, well, okay, she can finish everything outpatient, but she looks good, and they discharged her. And she was fine until the next time it happened. And it would be maybe once a month, maybe once every month, and it was that same thing all over again. And he would fret, and there must be something wrong. And so he would go back and forth, and finally he came into me. And this is where I say, like, well, let's just think about this. And this is not cookie cutter medicine, and we're gonna treat her, and we're gonna collaborate, and we're gonna come up with a plan that we're all gonna be happy with. And I looked at him and I said, how about if we just allow her to have a bad day? On the days that she wakes up, I don't want you to fret. Just leave her alone. She does seem to be okay drinking fluid. Allow her to drink, help her to the bathroom. And he said, what about the meds? I go, don't worry. One day of medications, it's okay. She's 92. It's okay. Just let it go. Do I think anything is seriously wrong? No, and I'm gonna tell you why. Because the very next day she wakes up, and she has a full meal, and she takes all her meds, and she goes to play cards, and she goes for her walks. So I don't know what it is. We never figured it out, but that plan that we came up with brought them both peace. He wasn't badgering her. He wasn't fretting. He was calm, and they did that, I think, like over a year. She would just have her little spells, and that was okay. And so that was plan that we came up specifically for that one couple. She ended up dying about a year and a half later of something totally unrelated. But that's the difference between gerontology medicine. I just want to tell you that story before I end, because I think that's my about 44 minutes. So, any questions?
Very interesting, Martha. But my question is, do you practice gerontology here at John Knox?
I did not get a gerontology, no, I did not get certified, because at the time there was none. So there was a year where they said I could get a certification, so I got the book and started reading it, to take the test, and then in the end they said no, they changed their mind, they want me to go through and take a whole course again, and go back to school for a second degree. So
you don't.
no, but I do what a gerontologist does, in other words, it's, yeah. Joe, I'll tell you what, the fact that I can take the time with you, the patients, the 40 minutes, 30 minutes, whatever, that is something that Joe Trainer, when he came on board and I was still here, he sat down and he goes, I want you to provide good service. I don't want you to worry about generating a revenue. I don't want you just focus on taking care of these people. So in my head, I wanted to do gerontology and a little bit of the VIP service that people get when they get concierge medicine. So we are able to arrange for transportation. We are able to make telephone calls to the specialists. And most of the local specialists, I have their cell numbers in my phone, so I can have a doctor-to-doctor conference. So it is a little bit different. A lot of my patients have my phone number, yes, in there, so they can call or text me if they're having an issue. I spend a lot of time involving the family members. That is a huge thing, especially if you, the patient, want me to involve your family. So one of the best things when I talked about labor and delivery and offering a good experience with life, when it's time for people to pass, you don't want your children to be burdened. You don't want them to have the burden of what could I have done differently, what should I have done differently. So no woulda, shoulda, couldas. I really make sure I know the patient well enough, and so when it's time for them to pass, their children are comfortable with the decisions we've made at end of life. And so, you know, they have their grief, so I don't want them to be burdened. So that, yeah, that's something that I'm very proud that I can do.
Any chance our records may go online someday so we can access them?
The record, there's something called Cubico, and it's supposed to be coming out, and I thought, from what I heard, it's supposed to be like to start out with leaving messages and making appointments. So I'm not sure how that's going to align with getting records. That's it.